Thank AIIMS Jodhpur and especially Alok for giving me this opportunity. Straightforward, going into the talk. Today's talk may be a little, people may not like my talk, especially the experienced minimal invasive surgeons, because in the first instance I'm telling, my incision is not small as everyone says 5 centimeter. It is a minimum of 10 centimeter incision. So I would just like to justify that in my talk. If anyone wants to criticize, fine. So, that is what Alok told me to speak on minimal invasive in LV dysfunction. The first thing I would tell is please don't do a minimal invasive in LV dysfunction. So I would just like to show one of the videos where we could manage with some difficulty. So coming to the introduction, because of the rampant progress in PCI, surgeons are forced to take up minimal invasive surgery and also breaking their necks and backs. That is also part of the disadvantages involved in the surgery. So it avoids sternotomy, cosmetic, less blood transfusion, decreased ventilation, decreased pain. I don't know, I sometimes feel my patients get more pain. Decreased hospital stay, surely. Then, so the purpose of my talk is mainly for the beginners. I just want to show a few videos where they can get some tips. And the main thing, our purpose of our surgery should be, it should be equivalent to an open CABG. That should be our main purpose. What we have seen, many people don't talk about it. We keep hearing it when we are having a drink. Is that we can say we keep talking about less arterial grafts being used, vein grafts being used, or other things, poor graft patency, and when we talk to some of our students who are in the institutes, they keep telling us, sir, we have done a study of redo CABGs and we had got so many from minimal invasive CABG and all, who had been done maybe 2 years back. So what I want to mention in capital letters is don't compromise on the long-term results of your CABG. So almost from 2007 or 8 when we started, I had been using a big incision, and almost I am still in the same incision. Maybe it is 10 centimeter or sometimes 9 centimeter. And the next thing is do not do MIDCAB if you are having severe LV dysfunction, for sure. Emergency, don't do following PCI or any acute coronary syndrome, and if you are having a complex coronary anatomy. So these are like the absolute contraindications, because if you are having a occluded or a highly stenotic left subclavian artery, because when you want to do a total arterial, your inflow is always based on your internal mammary artery, so better don't do it to an open procedure, because you can use REMA as your inflow. In that case, severe COPD, actually patients with mild COPD are better candidates because their chest wall is so open, you have a lot of space to operate. But severe COPD, compromise in the pulmonary function, better not to do it. Emergency procedures and other things like I told, hemodynamic compromise. Comorbid situations like severe carotid artery disease, where you may have problem like if you want to go on pump, or intermittently if you are going into hypotension and all. Aortic atherosclerotic disease, because when you want to put a proximal, you have very limited area where you can put your proximals. Don't do it, because now we have faced problems. So that is why I want to tell all the beginners, no, never in your life try to do a minimal invasive with severe aortic atherosclerotic disease and all. The relative is severe obesity. These are like, it can be we can say robotics can be used. So I am not going to talk about that. Severe chest deformity, complex coronary anatomy, and intramyocardial. Most of the time intramyocardial we come to know when we have opened the chest, and especially in cases where if you need endarterectomy of 1 or 2 vessels, because most of the CABGs we get are I get especially where we need endarterectomy. Small vessels also better to avoid. Diffuse disease, heavily calcified, highly tortuous vessels, and also instant stenosis, because sometimes the vessel is very much inflamed and you don't know which is the correct place to graft. Sometimes you may have to graft distally or you may have to remove the stent. So these are all the situations which we should avoid. So these are the principles which I follow, our unit follows. Very careful selection, case selection. CT aortogram is a must. So we can do a TAVR protocol study where they do the complete aortic study up to the legs, so that you don't have any other surprises when you go for a femoral bypass or something. And if the patient has been studied earlier also, always do a echo the previous day evening, because we have seen fallen into problems because patient sometimes has got an echo 15 days back. He must have developed an MI or a pericarditis or inflammatory disease, pericardial inflammation. We don't know about it. We just take him and then we land in problem. Incision size is usually 9 to 10 centimeters for me. And why? Because I am comfortable taking out a long lima or a rima up to the bifurcation, and also we need a longer SVG. Venous graft, mark it with a pen so that you don't find difficulty in its rotation and all. And always use separate proximals for the right coronary and the OM. Don't use a single proximal. Y can be created for a vein on the left side. Suppose you have two vein grafts on the left side. Keep it as proximal, near to the proximal as possible, so that, or if you can do it as a separate proximal, also good. One thing which not many mention about or don't use is do a Doppler flow of your graft after you have finished the surgery, and revise the graft if you feel it is insufficient. Another thing what I usually do is, if I know, I usually explain to my patient that minimally invasive surgery doesn't mean that you are getting a superior quality surgery. Sometimes there is a possibility that I may not be able to get a longer lima, then I put a vein as a intermittent to cover the spare, cover the length. So these, we cannot say that you are going to get a complete advantage of a bilateral mammary from the open. So this is one important thing which I think many of our surgeons need to explain to the patient. And some of the patients, in fact, they go back to their home and think, they say, okay, please do it, you can do it. May not be everyone, but some of them are willing to do it, go through the sternotomy. So in LV dysfunction, I just want to take a slide. If we are having LV dysfunction like 35-40%, we can still do, and what we do is start Milrinone the pre-op, a small dose 1 to 2 ml 1 day before the surgery. What happens is the heart nicely becomes small and the PA becomes soft. Once the patient is induced, we can give a diuretic depending on how is the distension in the heart. Another tip is you can use a stabilizer to keep the RV and the pulmonary artery, which will be bulging up in your vision when you are taking the lima and rima. Then the next thing is, when you are still having difficulty or if you have faced any surprise after you have opened the thoracotomy, you can go on a femoral bypass or an axillary subclavian femoral vein bypass, or you can still extend the thoracotomy towards medially and do a transverse sternotomy, and you can go on an autofemoral bypass very conveniently, or an auto RA bypass. So cardioplegic arrest can also be used. Some surgeons do it, but not so frequently. So with this, I would just give a short, small videos so that just to show how I do it. So this is not a small retractor, it's a big retractor, but it is being designed with its blade being like a small C shape. One of the surgical manufacturers there, I think Dunham, most of you must be knowing. I gave a design to him and he made it in such a way so that it becomes very convenient. You can use it in a smaller incision also if you keep the blades a little more nearer. So that is the exposure you get. Then this is another spreader which I keep using because at that time when I started the rod type and lifting type system was not there. This was a modification of the Delacroix retractor which one of my friends in Delhi made it. And we over the time modified it in such a way so that we can reach to the lower end of the lemma also successfully by rotating it. So the lower blade which is there, I can rotate the retractor and I can go to the medial side of the incision and I can lift it up. So when in this way I can get up to the bifurcation of the lemma, and also helps me in some situations if it is I have a little longer blade also I can take out the lemma also. So this is how now this is a patient who has been a bit of LV dysfunction. You can say around 36%. You can see a huge heart. So still the lemma can reach up to the tip of the lowermost portion of the LED. Then another important tip is just take the stays. So once you are done with the lemma, you have to take stays. So you can take the valve suture which is pledgeted, so it doesn't get cut through. If you take other sutures, sometimes because of the stretch they can get cut through. And just above the top end where the ascending outer ends, you can take a stay there. So this is a very important stay to pull your aorta up. So this is also another, I think the same thing doing. Then one more tip is try to loop the aorta when you want to do a proximal, because especially you want to loop the aorta because the other side on the right side you will be having the RA appendage popping up, and when you are trying to clamp it will be coming in between your clamp. So if you use your regular umbilical tape, it will be difficult because it is a little thin one. So you can use a wider one which we do a ENT nasal packing, throat pack or something like this cut out from the drapes, and then you can lift up the aorta. So this is also an important tip which learned from one of the conferences. Then you need to have a good side biting clamp. The regular side biting clamps which we use in open surgery don't really fit there. So I did some randomly started using, and then we found out one of these clamps which is called HOPT clamp. I don't know, which is used in renal surgeries. I got it made through again one of our industry fellows. This works out well. And now you can see that the aortic punch which I have done, and it is clearly visible. There is not too much of bending, and it is all the video taken through a mobile only. So everything is like almost like an open surgery. And once you have done the proximal, you can see the proximal which is clearly visible, the OM proximal. Be careful that you have to have proper hemostasis here because it will go away from your vision later on, and it is difficult to take any bite later on with the lemma and all coming down. Then you take the pericardial stays. Then I'll just take a short video to show how your regular stabilizer can be positioned. You need not make separate holes for your Novo stabilizer, and nowadays the hospitals don't acquire them, saying that they are very costly. And we don't do everyday minimal invasive, so we are using the regular ones. So this is like the lemma anastomosis. The exposure is as in an open surgery, and the OM graft. Then once you have, because you have put a marker, you can orientate it properly, and you put the marker to where it goes, and then do the OM anastomosis. When you are doing the OM anastomosis, the medial side stays can be released, or you can make the lungs down a little bit so that the heart can be pushed to the other side. So then you have a final check. Once you have done that everything is not, everything is correct, the lie and all. So this was a real difficult case, but okay, we somehow managed it. So some special situations, like I just want to go quickly, like you can use vein as a Y when you want to do two grafts, one going to the ramus and one going to the distal OM, and you can Lima Rima, I think it has already been discussed, so I don't want to go into it. Rima harvest and all. So this is like you have created a Y. The Y will be a little lower side. If you can create it a little higher, it will be also better. It comes like more like a T than a Y. And endarterectomy. So now suppose you have a surprise and you find that the plaque is separating, you want to do an endarterectomy. So you should be able to do it. So that's what you can see. This was a LED endarterectomy, which we managed to do. We don't do it regularly. Mostly, if we have a case, we go by an open method and do it on pump. So this is the Lima to LED anastomosis for an endarterectomy vessel. So after this, I would just like to mention a case report. I had a patient who a few months back we operated, 65-year-old, he was moderately obese, left main. I needed 2 grafts. He had undergone renal transplant 10 years back, absolutely normal graft renal function. Had a little bit of tuberculosis lesions in the lungs where treatment was started, and after 6 weeks we posted him for surgery. So when we initially checked his echo, which was almost 2 to 3 weeks back, it was good LV function or moderate LV dysfunction. We didn't check his echo, it somehow missed before his surgery. In the OT, we didn't get a TE to be put, and then when we opened, we found that there was severe pericarditis, and the whole pericardium was stuck with a lot of pericardial effusion, and his LV had become severe LV dysfunction, and we had to go on a femoral bypass. We extended the incision to a full thoracotomy, and there was a lot of time taken for the surgery. We did the proximal on the bypass. When we put the cannula into the right femoral artery, it crossed the renal anastomosis, where the graft was put, renal transplant graft. So the kidney didn't receive blood during that surgery time, and he was not passing urine. Later on, he had to be put on ECMO. So these all things I think we should avoid. Surely, if you would have done an open surgery, and luckily the patient got discharged after paying a huge bill, but sincerely speaking, we should avoid this. So in conclusion, I would say MIDCAB in a LV dysfunction, better don't do. Can plan if we have good vessels, 1 or 2, and we are very sure that he is having a good or a manageable LV function. Always have TE, never compromise on TE. Change your plan if you find any surprises on echo, and do a elective CPB instead of going on an emergency bed. Thank you.